Very cool.
Morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they will be addressed.
Good morning, everyone. I'm honored to introduce our mentor for today, Dr. Jill Salazar. Dr. Salazar is a board-certified emergency physician and educator. He serves as medical director in the EMS and fire department to teach both initial and continuing emergency medicine education for emergency medicine technicians and paramedics. In addition, Dr. Salazar also serves as an associate chief of service at Parkland's emergency department and liaison to surgical services. I would now like to request Dr. Salazar to begin today's session. Thank you.
Thank you so much for having me, everybody. It's really an honor to be here today. I am eternally grateful for the opportunity to spend a little bit of time with you. And I am very delighted you all came to spend some of your summer day with us. I know it's early for a lot of you, a little bit later in the day for others, but hopefully today you're going to pick up a couple of things. My goal for you today is to learn at least one thing that you have never learned before. That's goal number one. Goal number two, I would like for this to be as interactive as we can possibly make it. Looks like they're working on this window. Okay, guys, I am going to move to another location. Please forgive me. They're literally working on this window right now. I promise it'll be fast.
No worries. We don't hear any background noise or anything like that.
It's literally about to get kind of loud. I'll move, but I am ready for it.
Okay.
I am so sorry, guys.
No problem.
Okay, alternative location, check. How is this?
Perfect.
Okay, guys, so literally they're changing our windows now. We had a big storm a couple of weeks ago here in Texas, and so we're getting the windows replaced, and I knew sooner or later these guys were gonna show up, so they did, but we were ready for it. So my second goal for y'all today is to make this as interactive as we possibly can. So if you have any questions, put them in the chat, and we're gonna have some Q&A at the end, and I've designed some questions for y'all's assessment today. So please feel free to kind of interrupt me at any point. This is gonna be a nice chat. I'm gonna start screen sharing. Okay. Okay. But now give me a thumbs up if you can see my slide set. Okay. All right. Thanks once again. My name is Dr. Gil Salazar. I'm an emergency physician here in Dallas, Texas. I'm an associate professor of emergency medicine at UT Southwestern Medical Center. I also serve as medical director for Hutchins Fire Rescue. Hutchins is a small city just south of Dallas. So when I'm not working clinically or teaching our residents and medical students, nursing students, PAs, I spend quite a bit of time with the fire department, assisting with their medical operations. And every couple of days, I also get to be a firefighter. So I get to do some things that are really outside of the ordinary. All right. So let's start by telling you a little bit about emergency medicine and what that entails. We're also going to do a little bit of clinical cases as well. But really, I have one big motto that when people ask me what emergency medicine all about, I usually tell them that I have a very cool skill set. I have the capability to take care of anyone, no matter who they are, how old they are. I can take care of anything that comes through our doors, either in the hospital or with my subspecialty work outside of the hospital. I can take care of patients and their conditions no matter the time of day, whether it's morning, day, night, rain, shine, snow, it really doesn't matter, in really any place. So this is me right there with doing my work with the Dallas Stars. I am board certified in emergency medicine and emergency medical services, which means that I have a skill set to work with patients in the out of hospital arena. And part of my training involves sports medicine. So I am one of the team physicians for the NHL's Dallas Stars. And so when we talk about kind of taking care of anyone, yeah, we can also take care of professional athletes. We can take care of anything. We have some very specialized, sometimes very scary injuries that happen to hockey players, really any time and really any place. I've taken care of patients in cardiac arrest, players specifically at the arena themselves. So I have a very, very cool skill set. If you're ever thinking about emergency medicine, kind of think back to this slide, and that's really kind of the motto we do. And so that's me right there. That's Antoine Hudobin. He is the goaltender for the Dallas Stars, and he's a bit of a goofball. So I thought I would sneak this picture of myself with Antoine behind me, because otherwise he would probably try to photobomb it without me knowing it. So let's begin with a clinical case. One of the things that I want to make sure that you guys understand is that one of the big reasons for me to be here today, this is my way of thanking all of you for staying home. I know it's been tough with school and managing a lot of your day-to-day responsibilities virtually, and that helps me and my colleagues who work in the hospital stay safe. It helps you stay safe. Please do, guys. This is the real deal. And the Delta variant that is here is it's a bear. We're going to begin with the case of a 38-year-old gentleman with a history of high cholesterol, which we call hyperlipidemia, with 3 weeks of ongoing, very terrible, relentless cough, shortness of breath, which we call dyspnea, and some fever. He was diagnosed with COVID-19 approximately 2 weeks ago, was doing relatively okay. But as we know with COVID-19, you never say never. So he presents back this time with high blood pressure at 146/88. His heart rate is high at 110, a respiratory rate that is elevated at 22. Normally, it should be between around 12 to 18 normally, a temperature that is 99.3 Fahrenheit. And you can see his oxygen saturation, which we call SpO2, is 87%. Normally, it should be higher than 94, 95%. Okay. This is his chest x-ray. I'm gonna just kind of walk you through it. Normally, what you're looking at is the patient looking at you. So what's on your left-hand side is gonna be the patient's right side, and what's on your left-hand side is gonna be, on your right-hand side is gonna be the patient's left. You can see that normally on both sides of the field, kind of butterflying, are the lung fields, and air is black. So all of that really, for the majority of it, should be black. What you see in the middle is the spinal column right there, and you see kind of on your right hand side, the patient's left, that little kind of circle globular region, that is the heart border. What you're going to see that instead of black in those butterfly fields right there, you see a lot of haziness, a lot of cloudiness, as this is fluid in the patient's alveoli, in the little air sacs. And this is what COVID-19 does. It creates a superbly terrible inflammation in the airways, and inflammation normally manifests itself with fluid. And that's what happens at the alveolar level. And so it is no wonder that the patient comes in with shortness of breath, bad cough, and a low SpO2. So how do we take care of that in the emergency department? Well, let me tell you kind of one of the scariest, one of the saddest things about COVID-19. Pre-pandemic, a lot of these patients who have such a low oxygen level, who have this amount of fluid, would normally need very aggressive, we call it ventilation, air through artificial air pumped into their airways, into their windpipe. That requires very special equipment with a ventilator. It requires special resources in the intensive care unit. Well, surge after surge after surge with COVID-19, it depleted ICU beds, it depleted ventilators, and we had to get very creative on how to provide these patients oxygen, how to give them relief, and how to keep them from dying. And we started using a lot more of what we call high flow. So what you're seeing here is a picture of kind of a high flow oxygen setup right there. And really what high flow oxygen is oxygen delivered at a high rate. These patients need oxygen at very high levels, higher than normal, to keep their airways open and maintain a good oxygen reserve so that their blood cells can function properly. Additionally, they also need this oxygen level. When we're providing it to this degree, it can really dry up your oral passages, your nasal passages. So what you see right there on the patient's right is kind of this bag of fluid hanging. So we normally pump some of that fluid into these chambers, and that actually humidifies the oxygen. So as to make this high flow oxygen at a very high level, at a very high concentration, more tolerable for the patient. And so the method behind this madness is to keep these patients from getting on the ventilator. Sometimes we used it as a temporizing measure until we could get a ventilator. But it also kept a lot of patients from being intubated, a lot of patients out of the ICU, so that we can devote those ICU beds and ventilators to quote unquote sicker patients. So to anyone who ever said that COVID-19 is not a big deal, that it's a hoax, that it's just like the flu, they have never seen a patient literally struggling to breathe for their lives. And it's one of the scariest things. And we in healthcare had to make a lot of sacrifices, not just ourselves, putting ourselves in danger, and we continue to do that because it's the right thing to do. But we had to get really creative, use our brains, our brain power, and put it to really good use with these patients. So this is one of the ways in which we did it. Okay, let's go back to emergency medicine a little bit. I get a lot of questions about what it takes to become an emergency physician. This is Dr. Chris Nelson. He is one of our third year resident physicians. And Chris has been working literally an entire lifetime to get to this point. And here he is taking care of a critically ill patient with COVID-19 who needs specialized access in their veins. Sometimes the veins that we can get in our arms, for example, are not enough. And sometimes we have to deliver a lot of medications to critically ill patients. And simply one or two IVs is not going to cut it. You see that this patient is needing several medications hanging from the pole. So you can count right there in the brown bag, that's 2. Then there's another bag, that's 3. There's a little white bottle, which is sedation called propofol, that's 4. Then there's another bag, 5. And then there's another tubing, that's 6. So in order for us to be able to deliver that number of medications really at the same time, it requires us to access a patient's central blood vessel. So what Chris is doing, he is inserting a triple lumen, a 3-port big IV into the patient's internal jugular vein. He did so under ultrasound, and then he places it, and we're then able to deliver all of those medications a lot closer to the patient's heart. In order for folks like myself and Chris to do that, we had to get our bachelor's degree, of course, our 4 years of medical school. And emergency medicine residency is between 3 and 4 years. Most commonly is going to be 3 years. You may want to remember that. A little birdie told you so. And some of us choose to pursue additional training, 1 to 2 years of what we call fellowship, in which you acquire an additional skill set. That's one of the cool things about medicine, is the skill set that you can acquire are really endless. Of course, you can't know everything or get every skill set known to man, but you can sometimes be crazy like me and want an additional skill set. So for example, me, after my residency, I went ahead and did my emergency medical services fellowship I told you earlier, that allows me to take care of patients in the out of hospital arena. I get to play with the fire department. I get to do law enforcement as well. I get to do sports medicine. I get to do disaster medicine, etc. All in all, to tell you that folks like Chris Nelson are superbly talented, but it is, imagine the amount of sacrifice that it takes, the amount of time of personal sacrifices, both financial and physical, that we have to make to get to this point and be of service to patients. And it's not for the faint of heart. Oftentimes, folks try to think about what they want to do with their lives, and they're thinking about kind of emergency medicine as a possible career, and they want to know what are the challenges that we face in emergency medicine, what makes it different from other specialties. And the best way I can describe it to you is that in emergency medicine, we have a skill set that allows us to take care of very, very intricate conditions and perform very intricate procedures in very precarious, very dangerous parts of the body. This is Dr. McKenna Ferguson. She is one of our third-year emergency medicine residents, and much like Chris Nelson, spent a lifetime getting to this point, and she is able to perform a very, very intricate procedure. Here she is draining an abscess in the patient's mouth. And you can see that she needs a steady hand, a steady set of eyes, and actually coach the patient through holding that laryngoscope, that light, so that the patient can tolerate it a little bit better. Now, I'm going to give you a little bit of a teaser. Our virtual clinical observation program, which I run, and we actually finished our 6th and last episode. We now have those available for registration and for you to view them on your own time. They're all pre-recorded. So at the end, I'm going to put a link to the registration there. And in that, in our very last episode, I actually show you what McKenna does here, what she actually gets out of that body part. I'm not gonna spoil the surprise for you, so it's just a little nudge. See if you're interested in learning a little more about what we do in emergency medicine. Please take a look at us at Virtual Clinical Observation Program. So you can see right off the bat that the amount of focus and concentration that Dr. Ferguson needs to take care of this very painful, this very dangerous condition is second to none. Let's do another case. Let's before we do this case, any questions in the so far, guys? Anything that you are wondering about? I'm going to take a little swig of my water while we do that. Okay. If there are no questions, we'll just proceed and save them toward the end. We have now this is one of the most kind of telling cases of this pandemic. We have a 22-year-old woman who diagnosed with COVID-19 the day prior. This patient had attended a 4th of July party last year with a lot of indoors component to it, and nobody was masking at the time, not taking any precautions. She did acquire COVID-19, and the next day after her diagnosis, she comes to the emergency department for bad chest discomfort, inability to catch her breath, which we call dyspnea, and fever. Her blood pressure is unremarkable, a little low, but she is young and she is on the thinner side, so her blood pressure can be a little lower. She is very tachycardic at a rate of 121. Her respiratory rate is very high at 24. She certainly has a measured fever, and her oxygen saturation is low at 93%. I'm going to orient you to her chest x-ray, and I'm going to make life a little bit easier for you. Once again, the patient's, what you're seeing on your left-hand side is the patient's right, and what's on your right-hand side is the patient's left. You see that right next to the heart border, right there where the arrows are, normally you should have a nice, deep line that's black, full of air. Instead, you see that it's just kind of lazy and kind of raised and white. That tells me that there is something right there at the base of her left thorax, of her chest cavity. And we put some arrows on there. The differential diagnosis, the list of potential things that can cause this are things like fluid, things like pus, things like blood. And with COVID-19, we know that, remember we talked about fluid. Well, these patients can also develop secondary infections as a result of the massive inflammatory response that they are mounting, the amount of mucus that they're mounting, the amount of swelling that they're mounting. So when we have a suspicion about what things are, but we don't exactly know what they are, we have a lot of cool toys available to us to better delineate what's going on with the patient. So we obtained a computed tomography, a CT of the patient's chest, and we use contrast to try to delineate kind of what are blood vessels, what is fluid, etc. And we inject that into the patient's vein, and then we take a picture. This is a cross section of the patient's chest. Really to orient you, pretend that you have the patient in front of you laying down, their feet are closest to you, their head is away from you. Then you're taking a slice right there. And so you see a slice of the patient's chest. Okay. Once again, just like on the chest x-ray, on your left is the patient's right. On your right is the patient's left. You see the hard border there in the middle at the top. Um, Looks like a horse's hoof. That is the heart right there in the blood vessels. And then you see at the bottom of the left, the patient's left thorax, you see that there's kind of a layering amount of gray material there. You don't see it at the base on the right-hand side. It's kind of nice and clear. And can you see my cursor, Amna?
Yes, we can see it.
Okay, cool. This is the area that I'm referring to right there. Okay, and so we know that that there is certainly a collection of fluid in there, and that is most likely an infected collection of fluid right there. That is not, so the patient is not just sick from COVID-19 and struggling with the fluid, but now she's got an infection on top of that. Okay. At the time of her CAT scan, she remains persistently tachycardic with a high heart rate despite what we're doing and giving her fluids and antibiotics. She remains febrile, and now her blood pressure is getting lower and lower and lower, indicating to us that she is not compensating well anymore. As this is what's scary about COVID-19, perfectly healthy individuals, not much older than you, perhaps even the same age, literally dying, struggling to breathe from something that was completely preventable. Okay, so what is happening with this patient is that we have that secondary infection on top of what you're seeing. So some of the most common bacteria that can do it, Streptococcus and pneumococcal species, and the patients can develop this inflammation of the lung tissue, which we call pneumonitis. And I would like for you to write down what ARDS is. I didn't want to spell it out in here. So I want you to do a little bit of homework on this one. ARDS stands for Acute Respiratory Distress Syndrome. Once again, Acute Respiratory Distress Syndrome. And I'll give you a little bit of a teaser. It has to do with the amount of inflammation and fluid the patient has. And this is really what gets patients with COVID-19 in trouble. This is generally what lands them in the ICU on a ventilator, and this is generally what takes their lives. Sepsis is the overall body system's manifestation of infection, and sometimes even when properly treated, the patients can still deteriorate and they die. This was one of the saddest times of my career for me during this pandemic, is having to notify family members that their loved ones had died, and they can't really wrap their mind around how a young, healthy woman can die from something when the entire world has been aware of it, but then there's another faction telling them that this is not a big deal and that it's not worse than the flu. How can this happen? It creates this kind of conflict in families' minds, but it becomes all too real when they have to get on an iPad and with me and my team and be notified that their loved one has died. Then it becomes really real. I tell you this story because we have been fighting misinformation. We have been fighting political um, rhetoric and anti-science rhetoric for a very long time. And if these individuals who continue to push that ever had the opportunity to explain to families why their loved ones died, perhaps they wouldn't feel that way. And we continue to be doing that. So I ask you to please be good advocates for science. I urge you to get vaccinated if you haven't, and remember that really the only way that we're going to get through this pandemic is through vaccinations. Natural immunity, herd immunity is not going to happen. Let's all do our part to end this pandemic and not put clinicians like myself in the position where we have to continue to see people die from COVID-19. When we sometimes we get asked, how do you guys know so much, and how do you train, how do you keep your skill set up? Well, in order for you to become an excellent clinician, an excellent professional, especially in emergency medicine, we practice and we practice and we practice and we practice until we can't anymore, and we practice until we fail. You may want to remember that. We don't practice until we succeed. We practice until we fail so we can find weaknesses within our training, within our skill set that we can perfect so that when we are doing it and performing these procedures on live, real patients, we succeed 100% of the time. So once again, we train until we fail. That is a group of my residents. We train every single week. We got Dr. Uh, Santa Maria there on your right, Dr. Rodriguez is the next one, Dr. Aman Pandey is the next one, and this Dr. Paladugu, Sravana Paladugu is right there on your left-hand side, and that's me in the back. And right there, we are training for something called transvenous pacing. Sometimes when a patient's heart rate is very, very low, we have to introduce an electrical stimulus into the patient's heart to get it to beat a little bit faster. So we introduce a catheter in the patient's internal jugular vein, actually the same vein that Dr. Chris Nelson was accessing earlier for that big IV. We actually introduce a different type of IV and pass an electrical current into the heart to stimulate it. As you can imagine, the process of accessing that vein just by itself is difficult enough, but then introducing electricity and knowing how much, how little, and how often, that's a very specialized skill set. You got to know the equipment and got to know it with your eyes closed. And so that's why I'm telling you that we practice and we practice and we practice some more until we fail. And we do that every single week, both didactics and psychomotor, we call them hands-on type of practice. So if you want to be a good clinician, especially a type of clinician that requires a lot of manual dexterity and very procedurally oriented, like emergency medicine, you are going to be training a lot. Let me see what is in the chat right quick. I'm going to handle some questions. What is the fluid in the lungs and how do you proceed to remove it? Yeah, that's a phenomenal question. There are many types of fluid for the patients, like in the patient that I showed you, the two cases that we've seen before. If it's an infection, we treat it with antibiotics, and that should kind of take care of the fluid. If it's another type of fluid, we can sometimes give the patient diuretics to basically let them urinate the fluid out. Sometimes just the oxygen support and the ventilation support itself can kind of take care of the fluid. And with COVID-19, it's caused primarily by the big inflammatory surge. So these patients also need anti-inflammatories, and that generally takes care of the fluid. Tabga, when you had a family deny a COVID-19 diagnosis, what are specific statements you make to break the misinformation? This is one of the toughest things for us to fight because uh, due to social media, misinformation, or political affiliations, you name it, patients don't want to have that conversation. They've already made up their mind. And even if you have all the objective data in the world to tell them that it's COVID-19 or you have COVID-19, or it's still just a humongous barrier to fight. So much so that we approach it as professionally as we possibly can. I don't argue with people anymore about it. And the best way for me to mitigate kind of putting that stress on myself is by reminding myself that I was not the cause of the misinformation. I've spent a lifetime advocating for medicine and science, and I've done everything I can. And if this patient and their family um, choose to not heed my opinion as a scientist, as a physician, that is not my fault. I'm going to continue to treat the patient as I would my own family member, and hopefully eventually they will have a moment of clarity, a moment of maturity, and grasp the concept that this is a real disease and that it becomes too real in their own minds when they can't breathe or their family member dies. So yeah, very very tough to mitigate that problem. I hope it gets better. So thank you for your question, Topka. Let's continue with the presentation. Um, what about the skill set? We talk about the skill sets that we have. So let's kind of dive into that a little bit more and be more specific. This is Dr. Nate Hansen. He is the one kind of looking down and holding that instrument in his hand. Nate is a second year resident in our program. And here he is introducing an endotracheal tube into the patient's windpipe, into their trachea. This is a patient who had really bad seizures, who came in seizing and was not responding to the treatment that we were providing him. So one of the things that we have to do when a patient is seizing and they don't have good ventilation or oxygenation, we actually protect their airway by introducing an endotracheal tube. And what I want you to kind of note here is that emergency medicine is very much a team sport. I never do anything by myself. I rely on my team, and I rely on my team a lot. And without my team, I am absolutely nothing. And I will go to my grave thanking my team for being there for me and for allowing me and permitting me to provide really good care. You can see that Nate is being assisted there by, that is Lauren on his right-hand side wearing the light blue scrub. She's a respiratory therapist. Behind him is Mr. Wells. He is a paramedic student and one of my students as well. On Nate's left with the pink gloves is one of our nurses, and then holding the tape just closest to you with the blue gloves, that's going to be another one of our physicians ready to assist Nate with securing the tube. So what is our skill set? What do we pride ourselves on in emergency medicine? Number one, we can literally bring the dead back to life. We are experts in cardiac arrest and resuscitation. And although there are many, many great physicians and specialties in the world, really nobody else does it as well as we do in emergency medicine. That is our bread and butter. And so we take it to the next level, and we're very proud that we are the experts in resuscitation. And remember, I was telling you, anytime, any place, no matter what, cardiac arrest is something that can happen to anybody at any time, at any place, and we're ready to step up and resuscitate that patient. Other kinds of cool skill set that we have: airway. We are the experts in placing emergency airways in individuals, and we use a lot of cool toys to do that and train ad nauseum until we fail. We are also experts in trauma resuscitation, no matter the type of trauma, whether it's blunt injury from car accidents or penetrating injury like gunshot wounds, stab wounds, etc. We are the experts in taking care of those patients. We are the experts in helping assess and make the diagnosis in patients with stroke. We are the experts in assessing, making the diagnosis, and starting treatment on patients with heart attack or myocardial infarctions. And we are also very prideful in our assessment and diagnosis and treatment of patients with sepsis, which we mentioned earlier is an overall body manifestation of infection. And so that is one of the main killers of patients coming to the emergency department, and we are the experts in taking care of that. So that's why we do as much schooling as we do, guys. And like every other specialty, we have a very huge skill set, and we practice and we practice and we practice, and we go to school for a very long time to do so. Okay, so who do we take care of? We mentioned anybody, any place, anytime, and really anything. Who are the people that we take care of? This is my good friend, Dr. Justin Evans. And yes, Dr. Justin Evans. We are very proud to take care of anybody that comes through our doors, whether it be kiddos, taking care of kids that are literally, we deliver them in the emergency department sometimes. That little. We have older patients. My oldest patient that I've ever taken care of was 107 years old. We take care of patients with HIV, patients with different types of cancer, the LGBTQ community. We take care of those individuals as well. We take care of immigrants. We take care of pregnant patients, those with special needs and disabilities. We are also experts in assisting patients with behavioral health and mental health emergencies. And every once in a while, even fellow physicians come to our doors. So on this fateful day, I got a phone call early in the morning as I was getting ready, getting started on my shift, and it's Dr. Justin Evans, whom I've known for a very long time. And he said, "How you doing? I am so sorry to bother you this early, but my dog he pulled me, he yanked me really hard. I fell forward and struck myself against a concrete stairwell, and I'm bleeding really, really bad. Any chance you can help me?" Uh, as um, as you would imagine, we take care of anybody no matter what. And I told Justin, "Come on over. We're happy to help you." So Dr. Rebecca, you, who is right there on your right, and I are assessing Justin's lip. And this is another teaser for you to join a virtual clinical observation program, because we walk you through this very complex, very bloody laceration requiring very specialized, very skilled closure. So to make it your teaser a little more palatable, he actually has a pretty gnarly lip laceration with cosmetic um, considerations, and we had to pursue a very careful, very detailed, coordinated strategy in order to close Justin's wound. So you see that he was all bloodied up and got his auburn sweatshirt all bloody, but by the end he looked absolutely beautiful. And I hope that you get the chance to view that episode on VCOP. So all in all, to tell you that throughout your lives, people are going to put their trust in you, their lives on your hands. And how you choose to take care of that patient is completely up to you. But we do so with the utmost professionalism. We never close our doors to anyone, regardless of their insurance status, what they look like, where they come from. They are fellow human beings, and we're going to serve them no matter what. All right, let's see how we're doing on time. 9:38. That's excellent. Okay. Our next case is another very sad case, and I'm choosing to do all of these COVID-19 for today's session because I think it's very, very timely. This case involved one of the also tragedies with COVID-19 is that I hear quite a bit of, well, okay, I recovered from COVID-19 and the survival rate is 99.999%. Okay, that's great. I'm going to ask you two questions. Number one, in order for that survival rate to be what it is not magical, is not just inherent to the virus. Imagine the amount of resources and sacrifice that it takes to keep that survival rate what it is. Patients don't just recover. Sometimes they recover on their own. Okay, that's fine. But it requires people like me putting our lives at risk and in danger to keep the survival rate what it is, number one. So don't forget that when people want to argue about survival rates, the amount of resources and sacrifices the medical community makes to keep it what it is a big contributor to that survival rate. Don't forget that. And number two, remember that even if you recover from COVID-19, the long-term implications, which we are continuing to see, and they are more prevalent and more clear now, the devastating long-term effects of COVID-19 continue to be there. Such is the case with this 44-year-old patient, completely healthy Latino who had no previous medical history, hard worker with children, who developed COVID-19 a couple of months prior to this presentation. She recovered, but on this particular instance, developed a lot of shortness of breath once again, a lot of chest pain for the last 2 days. When we examined her, we noticed that she had decreased breath sounds on the left when we put our stethoscope on her. And we know that her vital signs are remarkable for an elevated heart rate, elevated respiratory rate, and low oxygen saturation at 91%. To get you oriented, remember that we talked about kind of lung fields and what they should look like. Well, as this is what patients with something called COVID-associated pulmonary fibrosis develop, scarring of the lungs. It's just this patchy cloudiness everywhere, okay? And then what was even more surprising to us is that you notice the left is a lot bigger than the other side. And this means that the patient has a pneumothorax, a collapsed lung. Okay. And you can see that although you would like to see kind of some lung markings indicating the lung is well expanded, you see no markings everywhere. It's just straight up black. And you can see the patient's ribs. Outside of that, you see nothing. And you see just a sliver of the patient's kind of lungs right here. That lung is exceedingly collapsed. We took this x-ray after putting in a little, we call it a pigtail catheter, to try to evacuate some of that air and let the lung reinflate. And you can see the little catheter here. You can see that the amount of air in there was so significant that even despite our best attempts to try to suck out all that air and let the lung re-expand, we were unsuccessful. And we had to proceed to do a CAT scan to see exactly what we were dealing with. Okay, so once again, you see a lot of this scarring on the patient's right lung, and you see here on the left that lung is completely collapsed here with all of that surrounding air throughout. So it is no wonder that the patient can't breathe very well at all, and that air is just continue to expand and push down on the patient's diaphragm. The diaphragm should be nice and high, just like it is on her right, but here it is pushing everything down, and that's a very scary, very dangerous situation. Okay, so unfortunately, she is COVID-19 positive again. And the reason I tell you that is one of the other things I hear with COVID-19 is, well, I don't want to get vaccinated because I already had it. So I got antibodies, I'm protected. I am here to tell you that even if you had COVID-19 before, the protection that you get from the antibodies is going to be completely unreliable, completely unpredictable, and you can get COVID-19 again. You can also get COVID-19 even if you're vaccinated, but your chances of getting a lot sicker from COVID-19 are going to be lower. And so not only does this patient have that pulmonary fibrosis, this long hauler syndrome that we're seeing that creates patients chronic shortness of breath, chronic cough, chronic body aches, chronic headaches for months and months and months. And now she is COVID-19 positive again with a very bad pneumothorax, a very bad collection of air in her lungs. So absolutely devastating for a 44-year-old woman who more than likely will never be able to function the way she used to before. What ended up happening with this patient is that she wound up needing an operation to try to restore that get the air out of there, restore that negative intrathoracic pressure that we call it, and try to re-expand that lung. And she had a very prolonged hospital stay, greater than 4 months. So can you imagine? You have young children at home, and now they don't get to see their mother for months and months and months because she is sick and will continue to be sick for many years to come. On a more positive notes, one of my favorite things about emergency medicine is that we are one of the specialties that is the most committed to recruitment of women and underrepresented groups in an effort to increase diversity in the workplace. To that end, this slide shows two of my favorite people on earth. All my residents are my favorites. Dr. Joya Singh is on your right, um, and Dr. Ikra Zakaria is on your left. Um, Dr. Zakaria is actually a third-year resident, and she's a chief resident, so she is the cream of the crop. Not only has she um, done phenomenal in undergrad, but then medical school, and then now as a resident, she's distinguished herself, and she was chosen as one of our 4 chief residents in a class of 22. So that is very, very amazing. And Dr. Singh, she is a second-year resident, and don't tell her I told you so, but she is going to make a good case for herself to be a chief resident as well someday. Here they are practicing airways and mannequins. So when we're not taking care of patients live, even when we're working clinically, we still practice a lot. You see that they're using these fancy cameras with a cord and a laryngoscope. So those are video laryngoscopes. Really, the reason we use them is because they allow us, especially in patients with COVID-19, they allow us to see what we need to see and introduce an airway, a breathing tube, which you see Ikra holding. It's got that green cap on it. And Dr. Singh is using a tube introducer to also introduce that tube. It allows us to view all of the anatomy without having to get too close to the patient's mouth. One of the most dangerous things about my job in COVID-19 is that these procedures tend to aerosolize a lot of particles. And we take every precaution to mitigate the amount of particles that can hit us and enter our airways and get us infected. So this is one of the ways that we do it. You see on Dr. Singh's screen, you see that she's holding that blue kind of thin little big tube looking thing. Well, she is introducing that into the patient's trachea, and you can see that same tube in her screen. So she is able to perform this procedure without having to get too close to the patient's face or even using her own eyes. She's using the camera as her eyes. So that is, once again, we practice and we practice and we practice some more, and it's awesome that we get to do so with a very diverse group that includes a lot of women. So that is outstanding for folks like me who really care about the evolving face of medicine beyond the traditional fashions. Okay, time to move on to a little bit of advice, and then I want a lot of your questions. Medicine is tough. Medicine is remarkably tough. I spend a lot of time at work in all aspects of my life. And how are we able to do this? Well, number one, all of us work hard. I know you work hard. But the best piece of advice that I have for you in terms of kind of how to work hard is that you should aim to be elite at everything that you do. And by elites, I mean like special forces elite. You have to shoot to be the best of the best at what you do. And that should be your goal each and every day, no matter what you're doing, especially in your schoolwork, especially in your management of your time and your service to patients and your volunteerism. You have to aim to be elite at everything that you're doing. Number one. Number two, you are absolutely nothing without your family. Nothing. And if you think that you can blaze through medicine, kind of do your thing, and put family second, you're going to be sorely reminded that you're absolutely nothing without your family. So take care of your family as well. Do not forget them. Do not forget your roots. Do not forget to treat the patients that you see like they were your own family member. Never, ever, ever forget that. Next, in order for you to have a long, healthy, fruitful, productive career, you have to take care of yourself as well. Your physical and your mental health should have a very high place in your priorities. Okay. That is me right there with my team. And once again, see the word team right there. I never do anything by myself. I do cross training when at 4 times a week, and lately I've begun to take up more running now, actually more structured running. So I'm working out 6 days a week. And why do I do that? Number one, my risk factors for cardiovascular disease are very, very high. In one of our episodes, a virtual clinical observation program, I tell you my father's story, both clinical and personal, with his heart attack. And I hope that you take the chance to view that episode on VCOP. And you get to hear him too, and kind of see what he looks like. And so I aim to take care of myself so that I give myself the best possible chance to work as long and to be as healthy as I possibly can for as long as I possibly can. I think that even more important than physical health, I do all of this because my mental health is important to me. The goal for you in terms of mental health should be to have an adequate and very, very robust reservoir of mental health before you take on a career in medicine, because working in medicine will tax your mental health. It is tough delivering care in a very tough environment. And I love my team. I love my job, but it does take a lot from me. I do bring some of that home sometimes. And that's why having a good mental health regimen for me is important. And so please don't forget to take care of those two things. Sometimes you'll be blazing through school and you think you're the best of the best and everybody wants you, only to find that out that you do not have the reservoir that you need to take care of yourself. And if you don't have a reservoir to take care of yourself, you're going to have much less to be excellent at taking care of patients. Okay, I run a pretty hefty social media presence. I like to post things about my life, about my sports career, about my medical career. Here's a QR code for our virtual clinical observation program, and it. I hope this is the one. I hope it works. Um, I'm going to put it in the chat as well. And you can register and watch the episodes. We do charge a little bit, and that covers the cost of the learning management system. So you have access to our certificates. You can view the episodes as many times as you want. You can download the assessments, the certificates of attendance, etc. And it helps us give out scholarships, etc. So that more disadvantaged students that can't pay for the fee or have uh, have the benefit of that program also get to benefit. None of that goes into my pocket or any of my team's pocket. So let's hope to see you all there. Let's start getting some of your questions. I'm gonna see what's in the chat over here.
Thank you, Dr. Salazar. If anyone has any questions, they can feel free to ask now, and we will now begin our Q&A session.
Thank you very much for that incredibly informative session, Dr. Salazar. My name is Hamza and I'm from New Jersey. I'm matriculating into a joint BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine in Pennsylvania. To start off our Q&A, the first question we have is, what primarily inspired you to pursue emergency medicine over other specialties? And what did you complete in your residency?
Thank you, Hamza. Very nice to meet you, and best of luck in your journey. There's an assumption sometimes in medicine that you're going to have this like very profound moment where you're going to choose a specialty and like little angels are going to start singing around you and they're going to tell you pursue emergency medicine. I can tell you that for me, that was not the case. I did not have a kind of a eureka moment. For me, my decision to pursue emergency medicine came by way of an emergency medicine resident rotating with me as a third-year medical student. We were all in the same obstetrics and gynecology service together. And this emergency medicine resident, the cheerfulness, the collegiality, the smile, the energy, the vibrancy that she brought to our team, to me, it resonated with me. That was the kind of person that I was and I aspired to be. So I had never even been in an emergency department before, other than maybe a little bit of shadowing. But that is exactly what spoke to me right there. And so your decision to choose a specialty will sometimes be based on your pre-medical school kind of decisions and what really speaks to you. Sometimes it'll be because of a specific patient encounter that you had. Sometimes it'll be a mentor, and other times it'll be kind of random. And so my best advice to you when you're looking to find a specialty is keep your eyes open. Don't settle on one thing and be so linear in your thinking that you're thinking, I'm always going to be a breast oncology surgeon, and that is all I'm going to be. You're going to be surprised when you stop looking linearly. You look outside in the periphery, you might fall in love with somebody, with something else in terms of specialty.
Thank you very much for that answer, Dr. Salazar.
You're welcome.
Our next question we have is, do you feel like normally you have enough time to counsel patients even during busy days in the ER?
There is a finite amount of hours in the day, and um, patients really understand that in the emergency department, our interactions are going to be brief. So in order to mitigate that, we get really, really good at communication that is very directed, very goal oriented, and to give the maximum amount of interface with patients in a very short amount of time. We spend as much time as we need answering questions. And we're also really good at kind of having very tough conversations as well. So there's not enough hours in the day. And for every moment that I spend counseling a patient, there are other patients waiting for me. So we have to be very directed in the way that we do it. But know this: a patient is never gonna walk out of our doors dissatisfied with the amount of information we gave in a very short amount of time.
Thank you very much for that answer as well. Uh, Similar to our previous question about why you chose emergency medicine, on residency, where did you complete your emergency medicine residency?
I completed my residency at Louisiana State University in Baton Rouge at the emergency medicine program. That came right around Hurricane Katrina. I was inspired at the events of Hurricane Katrina, which occurred my fourth year of medical school. And when the dust settled from that hurricane and devastation and the death, I wanted to be part of serving in that community that was deeply affected. And so I ranked LSU very high on my list, and I was very, very fortunate to land there. And so the lessons that I learned from the beautiful people of the state of Louisiana will stick with me forever.
All right, thank you for that answer. What are some different types of sutures you use in the ER?
We use there are basically two big types of sutures. We use absorbable and non-absorbable sutures. Um, Basically thread, and the absorbable ones, the advantage is that we can leave them in place and the patient never has to come back and get them taken care of. They'll just kind of dry up, as will the wound, and they'll kind of go away and dissolve on their own. The absorbable ones, we use them, they have a little more strength to them. The patient does need to come back and have those removed with their own primary care doctor, sometimes urgent cares. We also use combinations of sutures. We can use absorbables and non-absorbables within the same ones. We can also use glue-based sutures, and once again we can use combinations of things. And really what you should remember about sutures is that it's not, people think it's like closing things. Really what you're doing is you're approximating tissue as best as you possibly can, allowing the tissue to kind of close on their own. So I'm not really kind of closing a wound. I'm approximating a wound and letting the body kind of do its own thing.
So this question isn't in this has been asked, but when you are, how much do sutures play in stopping bleeding? So how much of a role do they play in that?
You can place sutures. Sometimes you have to ligate to tie up vessels to stop bleeding, but closing a wound is not going to stop bleeding. Actually, if anything, is going to make it worse. You create a blood collection under the skin, and those can become infected sometimes. And so sutures don't stop bleeding. You can use sutures to sometimes tie up blood vessels that are continue to bleed, but that is of last resort. Just pressure. It's going to be your best bet. Sometimes we have to use tourniquets to stop bleeding. Sometimes we have to use hemostatic agents to stop bleeding, but sutures in and of themselves don't stop bleeding.
Thank you for that answer as well.
You're welcome.
Here's another question related to sutures. How often
I'm back, guys. Sorry, I think I froze for a second.
let me ask the question again.
Yep.
How often are antimicrobial sutures used for laceration management?
Antimicrobial sutures, we don't use them in emergency medicine. We cleanse and irrigate the wounds aggressively before putting sutures in. Sometimes wounds are not great candidates for closure, like some dog bites, for example. We try not to close those completely because infections can happen. So we don't use antimicrobial sutures. We fight that through cleaning the wound really good first, irrigating, preparing the wound before closing. Sometimes we have to put patients on antibiotics to do that.
All right, thank you for that.
You're welcome.
What is the difference between shock trauma centers and emergency medicine departments?
Trauma centers are referred to hospitals that have some additional resources for the care of the patients with trauma. And in order for some centers to be designated a trauma center, they need to have certain resources like radiology 24/7. They need to have operating rooms open with personnel 24/7. They need to have certain personnel available 24/7, like trauma specialized surgeons on call. You need to have availability of certain subspecialties like neurosurgery, for example. So for you to have that designation is a little bit different. Most emergency departments don't have a trauma center designation. They can function completely independent of those centers. Sometimes we have to transfer patients to a trauma center when we don't have those resources available to us.
All right, thank you for the answer.
You're welcome.
What could be the cause of complete heart block in ischemic heart disease?
Of heart block. When you have ischemic heart disease, remember that it can affect both muscle, it can affect the blood vessels, and it can affect the electrical pathways that help the heart beat correctly. And so when you're dealing with death of tissue, you can affect all those three things. And so one of the causes of heart block or in ischemia is going to be death of some of those electrical pathways that help the heart beat. Sometimes medications can do that. Sometimes other conditions, intoxications, and other disease processes like infections and sepsis can lead to heart block. But when it comes to ischemic heart disease, when it leads to death of heart muscle, all bets are off, and that heart's going to be very, very sick.
Thank you very much for that answer. What is the prognosis of cardiac arrest patients who have been resuscitated?
If they have been resuscitated by us, the best possible hope is that they will have a good neurological recovery. We are pushing more and more and more toward resuscitation that is geared toward proper neurological recovery. I'll be very frank with you. I think it's great that we can resuscitate folks, but I want to resuscitate folks, especially if it can lead to a kind of meaningful um, type of lifestyle where the patient can kind of function on their own and take care of themselves. I'll be very honest with you. Sometimes patients are resuscitated and they don't have a good neurological recovery, and they wind up um, fully dependent on others for the rest of their lives. So is that the type of life that a patient would want? I'll be honest, if you ask me, that's not the way I would want to live the rest of my life. So the hope is always to revive and resuscitate the patient to good neurological recovery. When it comes to cardiac arrest with certain types of rhythms, of arrhythmias that can lead to cardiac arrest, the recovery for neurological recovery is good. For other types of arrhythmias, it's not.
Thank you very much for that answer as well.
You're welcome.
This is a question that I also had. So how do you stay up to date on new research for novel treatments of COVID-19 and other cases you regularly see in the ER? Because as far as I can tell, you have to know about pretty much everything when you're in the ER.
Yeah, you sure do. And they're coming to do the windows now on this room, so I am going to move. I stay up to date by reading journals. I subscribe to no less than 3 journals that I keep on my person at all times, and I devote a few times a week to go ahead and read up on those. Now, I mentioned my conference that we do every week, and so we discuss journal articles. We do didactics once a week. So if you don't stay atop of the medicine will pass you by, and that's not a good place to be. So you have to be very diligent in how you stay up to speed, and that's how I do it.
All right, thank you very much.
Welcome.
All right. Which part of the lung is affected by the COVID infection?
All of them. The air vessels themselves, the bronchi, the bronchioles are affected with inflammation. The lung tissue itself is affected, and that can become fibrosed and scarred. The alveoli, the air vessels, the air pockets where gas exchange can occur, that also gets affected. They get filled with fluid and blood, etc. Gas exchange can't take place, and so every single part of the lung is affected in COVID-19, both in the acute kind of immediate setting and also going forward, especially with that chronic scarring.
Thank you. You already answered the next question we had, which was, can the COVID-19 infection cause pulmonary fibrosis? If I remember correctly, you said yes, it can.
Yes, 100% yes.
And after that, our question is, are we using monoclonal antibodies for the treatment of pulmonary diseases, especially COVID?
Yes, there is room for monoclonal antibody treatment in certain patients with COVID-19. I think the effects were not as robust in some patients as we hoped that they were, and not every patient is a good candidate for monoclonal antibody therapy. And folks should not kind of rely on kind of the thought of, well, it's okay if I get COVID-19 because they can use monoclonal antibodies on me, I'll get better. Nothing could be further from the truth. That type of therapy should be limited to a certain type of patients that meet very strict criteria with some good effects, but in my humble opinion, not as good as we hoped it was going to be.
All right, thank you. We have a few more COVID related questions. Is COVID-19 lung damage reversible?
It remains to be seen. We have folks now who acquired COVID-19 last year at the beginning of the pandemic who are still struggling with pulmonary fibrosis and long-term symptoms. We're beginning to think that the type of fibrosis and scarring that it causes may be very similar to other types of fibrosis and scarring that is non-reversible. And that's a very scary thing because you have high functioning individuals in our communities who um, have acquired COVID-19 and they were extremely active athletes, for example, children. I've seen it all now, and now are severely limited in what they do and can't do. And so I'm very concerned about kind of the long term aspect of it, and I'm really afraid that a lot of the damage that we see is going to be non-reversible.
Thank you. Is there any role of ECMO in COVID-19 pneumonia?
ECMO. So, if for those of you who may not know, this is a kind of a very specialized kind of a type of bypass procedure that we use in exceedingly sick individuals. We also can use it in patients with cardiac arrest, for example. These are very sick. So yes, there is definitely a role for ECMO in patients with COVID-19 and in the ICU setting. Once again, it's a very limited type of patient population that would benefit from it. And even then, if you have to be on ECMO, that means that you're remarkably sick and you already have a very tough prognosis to begin with. We have seen both successes and failures with ECMO in these patients. So I just hope and pray that when people think of ECMO, they think of it as really kind of, my goodness, my loved one is superbly sick and hopefully it'll work. But it's they're in a heap of trouble, to be honest with you.
Thank you for that answer. Related to being really sick, have you seen patients who receive the COVID vaccine and still get COVID pneumonia?
Yes, absolutely. I will tell you this though. I have seen patients who are in my practice who are vaccinated who acquire COVID-19. I will tell you anecdotally, at the very least, that some of these patients who are coming in now, had they come in, say, before their vaccination with COVID-19, I guarantee you they would have wound up in that category where they get on high flow oxygen and then on a ventilator and possibly dying because they have risks, especially when they have risk factors, obesity, diabetics, older. But now, when they're vaccinated and they acquire COVID-19, they're not as sick as they would have been. And so that matches a lot of the literature that we are seeing, and that's what we expected. These antibodies do provide protection from you from getting deathly sick. And so now I'm seeing it myself, and it's really reassuring.
Another question we have about COVID-19 is, how is the Delta variant different from other variants you have seen presented to you in the ER?
The original strain that we were seeing a lot last year doesn't even come close to Delta. Its infectivity profile is a lot scarier. And so, especially in non-vaccinated individuals. And so you have a very contagious, very aggressive, very elegant virus. And this is what viruses do. They get smarter, they get faster, and they get worse. And so these folks that we're seeing now, the majority of them are Delta, who are unvaccinated or coming in very sick. So my best advice to you is, even if you're vaccinated, still take care of business, because you can still acquire COVID-19 and it's more than likely going to be Delta.
Does age play a factor in how severe someone reacts to COVID?
Younger individuals without medical problems are less likely to develop severe disease. If you're older with risk factors, including diabetes, lung disease, immunosuppression, you are more likely to get sicker. Now, don't get complacent, because just like the notification that I told you earlier on that 22-year-old, I've done the same for 16, 17-year-olds, completely healthy athletes. And so, yes, it's all about um, chances. It's all about what are the probabilities, but it is not a probability I'm ever gonna hang my hat on for sure. Take care of yourselves.
I think we have our final question directly about the COVID disease. Can people with autoimmune conditions receive the COVID vaccine?
Yes, the majority should. Okay, the majority absolutely should. But for anybody with autoimmune diseases, they have to have a frank discussion with their primary care physicians, their rheumatologists, their oncologists, to absolutely be sure. There are not a lot of contraindications to getting the vaccine, including those who have autoimmune diseases, but definitely do have that conversation with your doctor about it for sure.
All right, thank you.
You're welcome.
Now we get back to normal questions. Given that emergency medicine is a specialty that pushes for more women and other underrepresented minorities to pursue, is it more difficult during emergency medicine residency to get a maternity or paternity leave?
Every specialty, um, every institution now has should have pretty aggressive, very forward-looking FMLA, family and maternity leave of absence, etc., practices and procedures. So, we certainly do at our own institution, so that female physicians who want to need the time off to take care of themselves because they're having a child or other situations in life have the ability to do that. So when you're looking for an employer to go work with, make sure that they have a pretty innovative, very modern approach to having leave for that. So is it easier in emergency medicine? Not necessarily. You're still going to be working a lot, but I think it's way more important to have a very progressive FMLA policy and procedure in the organization you're going to go work for.
All right, thank you for that answer.
Welcome.
Given you are running your own online clinical observation program, how would you personally compare or rank in-person hands-on experiences versus online observerships during the COVID-19 era? And how can we further polish online programs to allow for students to take the most out of online experiences?
Yeah, on in person has kind of the advantages of having the actual patient in front of you, facial expressions, that interaction between clinician and patient, so some of those nuances that are very hard to replicate. But what we learned in the online platform is that with the right structure to it, you can capture a lot of these nuances if you've done a lot of work on the front end in developing that experience. So for example, for this session that I gave you, it wasn't just kind of throwing some clinical cases at you and just kind of letting you have at it. We discussed a lot of the things that kind of went into it. What are the conversations that we're having? What are the dynamics, interpersonal dynamics that we're doing? So not only is it just kind of telling you about the treatment, this is what it is, but what are the other nuances that go into it? So an innovative online virtual education program should involve and integrate those aspects of that relationship with the patient into the structure. So is it ever going to be the same? No, absolutely not. But it will definitely give you a very good insight into what it's really like to be a clinician, especially when you're working in the clinical arena.
All right, thank you. I agree with that as well. So, do you provide letters of recommendations for medical or international medical students applying to match into emergency residency programs through VCOP?
We do not.
Right. What do you think was the hardest part of your journey to get where you are? And what do you think we should look out for?
There are many barriers in this country, especially for underrepresented minorities like myself. Um, I had a lot of great people cheering for me, a lot of great individuals who pushed me along, who gave me the resources and the opportunities. Yet in this country, we continue to fight racism. We continue to fight bias, especially gender and racial bias. And so for those of us who belong to underrepresented groups, that's a challenge, and that's out there. And so for your generation, I urge you to do better than my generation in terms of fighting those gender and racial biases. So how can you help? How can you mitigate these things? Number one is being an advocate yourself and your communities for fighting racial and gender bias. Let's all begin in our communities doing that, and then slowly but surely that's going to get better. Now, when you're in the clinical arena, when you're looking at opportunities to train and places to go, make sure that those institutions that you are looking at have made a very, very clear stance, have a very clear stance on racial and gender bias. And by all means, if there are red flags in those organizations, the, the way to speak up the loudest is by not supporting those organizations. So let's fight very hard to make sure we fight those things. So that was the biggest thing for me, and one of the reasons I like to do this is to really promote racial and gender equality in our community. So you guys do your part to it and do even better than my generation.
Got it. We'll do that. The next question we have: do you believe there's a need for more mental health resources dedicated for physicians due to the daily stress-inducing work environment, especially now given the pandemic?
Yeah, definitely. Phenomenal point. Um, COVID-19 raised that exact concern even early on. And the majority of organizations, including my institution, put programs in place very early on in the pandemic to mitigate that possibility, that problem. And so very early on, we had a group of individuals and departments putting resources at our disposal, um, to take care of our mental health, no matter what. And for that, I'll be forever grateful, because it's literally saved lives. So it was awesome to see non-emergency physicians step up to the plate and recognize that this was going to be tough on people like myself, and put those resources available to us no matter the time of day, with no questions asked. And so that's a beautiful thing. But we can always do better. We can always do better.
Thank you very much for the answer. What are some book recommendations you have for students interested in medicine?
Okay. I got you. You know, to be very, very honest with you, books about medicine themselves, I am not I've never been a medical book reader. There have been books throughout my life, though, that have given me inspiration and have given me kind of a push in my own personal life. And so I've always been a big fan of fiction. So um, I'm going to put in the chat a link to one of my favorite books of all time that really inspired me, The House of Spirits. It's originally in Spanish, and many of you have read it, but I'm going to put a link in the chat. So even though it's not medically related, I urge you to kind of find purpose and meaning and inspiration in things outside of medicine too, because that is also going to contribute to your success in medicine as well.
Thank you. I'll look into the book as well. And as for our final question, what are some resources you recommend for students interested in pursuing emergency medicine?
Resources and pursuing emergency medicine. There is an old show. It's called Trauma: Life in the ER. They no longer air those. This was a late 90s, early 2000s endeavor. in the A&E channel. So you may find some of those episodes still available, perhaps even on YouTube. If you really kind of want a glimpse at kind of what pure emergency medicine is all about, that is a great resource for you. I don't want you to start getting too much into like medical literature and stuff. Keep your eyes open, but that specific show gives you kind of a glimpse into kind of what life is like. A lot of the interpersonal interactions that we talked about gives you a fairly good idea about what life is really like.
All right. Thank you very much, Dr. Salazar. Those are all of our questions for today.
Okie dokie. Can I address one quick question, Hamza? There was one that I got by
Sure.
DM on non-US IMGs looking to match into emergency medicine. Non-US applicants have a really tough road, especially in this country versus US trained physicians. So my best advice to you is begin to network aggressively within your community. Start getting your name out there, getting your resume out there, so that when you are applying, you really have a network of individuals kind of vouching for you, pushing you along, and giving you inspiration. So start kind of in your local community and network aggressively.
All right. And thank you very much for taking out of your time, taking time to answer that one as well.
You're so welcome, guys. It has been a pleasure having you here, and I'm really grateful for the opportunity to spend a little bit of time with you.
Yes, thank you very much, Dr. Salazar. We truly appreciate you taking the time to answer our questions. This was a greatly informative learning session for all of us. I love everyone to please give a warm thank you to Dr. Salazar in the chat box for this incredibly informative session.
You're so welcome, guys. You're very, very welcome.
Again, thank you. Now we're going to conduct our closing session with our quiz and future session dates.
Thanks for having me.
The link to the quiz for this session is now live. Again, you'll need a 70% or higher to pass and receive certification, and that link is in the chat. Many of our students have expressed interest in pursuing a leadership position in teleshadowing. We do have positions open on our leadership page, as we strongly believe in extending opportunities to others. That link should also be in the chat now. Don't forget to join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox. You can join from the link in the chat now. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session next Saturday on July 31st at 10 a.m. Eastern Standard Time with our physician mentors specializing in orthopedic surgery. Thank you so much, everyone, for attending today's session. We hope to see you in upcoming sessions as well. This concludes this week's shadowing session.
Bye, all.